This conference will now be recorded.
All right, we got a reasonable number of people. Let's get started. Try to get through all of melanoma in an hour. So we'll go a little quick, especially through the first part. All right, who's on for interns? See Kat. Flynn's on. Okay. All right, so Kat, 70-year-old man who worked as a roofer for years, comes to you with a suspicious lesion. What do you want to do? Skin
Get a
lesion,
focus,
obviously.
get a history and physical on him. The
What are
physical
you looking for in
specific.
history?
So in history, you look for like history of multiple sunburns or a lot of sun exposure. You look for a history of melanoma in his family or some of the other genetic diseases as well that can put you at risk for that. So like familial FA triple M, which I can't remember what all the M stand for. Those types of things. That's what you're asking on history.
Yeah, I mean, what else? What more acutely are you going to ask about the lesion?
Has it been changing? When did you first notice it? Those types of things.
Yeah.
You know, like,
so I mean, I think the history of melanoma, history taken in melanoma is sort of oversold. Like everybody's had sun exposure. So I think, the things that you look for are people who have jobs that put them at sun exposure. So, especially on a test, right, it's always going to be like a farmer or a roofer or something where they've had a ton of sun exposure. Asking people about if they got sunburns when they were a kid, I think is a little silly. I don't know. I mean, everybody's had some sunburns. And then, where their kind of family, what their, genetic makeup is, where their family's from, people from, I should say temperate zones, not temperature zones, but, Northern Europe, being the most common, and then people who have fair skin, freckles, light hair, and then, like you said, family history. I mean, these genetic syndromes that cause melanoma are incredibly rare, so you need to know them for the test, but not for real life. And then, do they wear sunscreen? If they're a roofer or a farmer, do they wear a hat? Do they cover their skin? Those are kind of the things I think that you can ask. And really that stuff, in all honesty, is mostly for test taking. When in real life, most of these things are going to be sent from a dermatologist. Now, if you have somebody that you sort of incidentally note something on their skin, then you might ask all these questions if they haven't been worked up by a dermatologist, etc. But on the test, it's going to be, an older farmer, roofer, something like that, where they've clearly had a lot of sun exposure. All right, and then concerning features, these are pretty easy. Is there a med student on? Or Minsky? What are the ABCDs of melanoma? Having mic trouble.
having mic
Flynn.
trouble.
Yeah, Ashley, are you on? Clem, go find one of the med students to go through ABCDs. This is a hospital. Hold on one sec. Sorry.
I can do it. Here, I'll walk over now. Here you go.
Okay. So asymmetry, border, color, diameter, and everything else. Evolution. I can hear myself.
Did you hear that?
All right. Did you get through the ABCDs?
She did. She did great.
Excellent, good work. All right, yeah, so asymmetry, borders, color, diameter, and then E is evolution. So any of these being changing, that's concerning. Any diameter over 5 millimeters, you should biopsy. You know, all these things. It's pretty straightforward. All right, so that's scary looking, right? That's not good. Ashley, what do you want to do?
I would biopsy it.
Okay, how do you want to biopsy it?
I think if it's concerning for melanoma, you would just do an excisional biopsy to try to figure out like the depth, because if you do like a shave biopsy, you ruin it, I think.
Okay,
I
so
might be wrong.
you were right about what's wrong, but wrong about what's right. So,
Okay.
all right, so let's go to Franklin. Why do we not want to do an excisional biopsy of a melanoma?
We don't know the depth. If we just do an excision, we'd be removing all of it, but we wouldn't be properly staging the lesion without a punch biopsy.
Well, so that's sort of right. Keep your mic on, Franklin. So what do you mean by that? So so if you take it out, you excise it, and then it comes back, and you know, and it's
You don't know the
2
depth, so I
millimeters,
mean,
then,
if you do the wrong depth because you didn't know how deep the lesion was, you just did the wrong operation.
yeah, okay. So when you excise the melanoma, how deep do you need to go?
Well, so you need to go down to the muscle, down to the fascia,
Right. So you
when you
would
do a wide
assume that
local
if you're
excision.
yeah. So I think your point is fair, right? So if you do an excisional biopsy without treating it like a melanoma, you don't go down to the fascia, then you've kind of hosed yourself. But you can always go back and take more tissue. What's the real problem with an excisional biopsy? Clem?
So if you take off like a big whack of tissue and then you have, say like a T3 lesion, now you're gonna have to take a 2 centimeter margin on that large tissue versus just taking like a punch biopsy or an incisional biopsy where then you can,
You guys are, it's not the margin that you're hurting.
You're losing your opportunity to do a sentinel node.
Yeah, exactly right. So if you take more than 1 millimeter around the lesion, you decrease the accuracy of the sentinel node. So if you really need to do, like, let's say it's too small to punch, or you're going to end up doing basically an incisional biopsy when you punch, that's okay, but your margin needs to be very, very small, like 1 millimeter or less. If you start taking a 2 or 3 millimeter margin, and then you have to come back and do a real margin, you lose the ability to do a sentinel node. So that's the real problem with an excisional biopsy, is that you'll mess up the lymphatics in the area and potentially decrease your accuracy of your sentinel node. So what's wrong with a shave biopsy, Bobby?
You don't get an accurate, I guess, sense of the depth of the tissue.
Yeah, why does that matter though? Because again, you can always go back and take more.
I guess for the same reason. I mean, do you mess up the lymphatics in that?
It's not so much that you mess up the lymphatics, is that you don't know whether or not to do a sentinel node biopsy. That's the problem. So if they do a shave and you get this, like, 0.4 millimeter melanoma, but of a positive deep margin, you don't know what to do with that. Should you do a sentinel node? Should you not? You can't like go back and, I guess you could repunch the scar to try to get a depth, but most of the time you just hope that doesn't happen. And if it does, you might have to do a sentinel node, and it might be unnecessary, is the reality, because that's just the dilemma that you're put in. And the reality is that the dermatologists do shave. They shave nevi all the time because they feel like they're good at telling which ones are melanoma and which ones aren't, and sometimes they're wrong. It's not the end of the world, but it does kind of make your decision making difficult. So shave biopsy is wrong because you don't get a good sense of the depth and you don't know whether or not to do a sentinel node. Excisional biopsy is wrong because you'll mess up the lymphatics. So don't do an excisional biopsy, do an incisional biopsy, and most of the time that means a punch. Bobby, have you ever done a punch biopsy before?
Yes, sir.
How does that work?
not of a melanoma, but I think, I mean, you'd want, you know, a margin of what looked to appear to be normal tissue, and you just sort of apply pressure. You can potentially twist a little bit until it, and just kind of go, you apply downwards until you can kind of feel it free up and pull back up.
Yeah, so I would say, are you talking about biopsying the edge of the melanoma?
Yes.
Yeah, I wouldn't do that. You know, what you want to biopsy is the deepest part. So you don't always know what the deepest part is, and there are like fancy lights and detectors that some dermatologists have and things like that. But you just have to kind of guess a lot of times what the deepest part of the melanoma is, and you might be wrong, and you can punch it a couple times if you're worried about that. But you know, for me on this picture, I would just take the darkest part because I assume that's probably the deepest. Some people just take the center, but you don't want to take the edge because the edge might be, you know, thinner than the deepest part. And so you really want to get the deepest part because that's going to tell you what your next step is. So, but this is how a punch biopsy works for those of you that haven't done it. It's this little circular kind of knife, and you just twist it and push down like Bobby was saying. The reason that the punch biopsy is the ideal way to do it is because it gets down all the way through the dermis down into the subcutaneous fat. So you want to get all the way down into the fat, get full thickness skin so that you get the right depth. So that's the key. Okay, so what matters on the biopsy, Ashley?
The depth of invasion and the type of melanoma it is, maybe.
What do you mean by type?
There's like multiple subtypes of melanoma. I'm not so sure if that necessarily affects your surgical management, but it might affect your.
Yeah, it does not. So I didn't actually put a slide on that. That's a good point that you bring up that I kind of forgot about. For the abscess, you need to know. So there are 4 types. Kat, what are the 4 types of melanoma? Actually, you have to help her because you brought it up.
Yeah, so the 4 types of melanoma.
What's the most common?
I have no clue what the most common is.
Okay,
I know
let's go through
they,
the 4 then.
So the 4 types of melanoma, you have lentigo maligna, which is superficial, or which just spreads superficially. So it transits radially, that has the best prognosis. You have superficial melanoma, which is different. That's still got a decent prognosis, but can be bad. You have acral lentiginous, which is on the hands and soles and feet, and ungual, so underneath the nails, and that's typically African American people or dark-skinned people who get those. Mm-hmm. That's more intermediate kind of prognosis. And then you have the acral, or then you have the nodular, which is usually metastatic at the time of finding. It goes deeper at first, so it grows depth-wise, and that has the worst prognosis.
So in my mind, I put nodular and superficial spreading kind of into a group. Superficial spreading is the most common, and it's also, you know, relatively good prognosis because it spreads superficially, not deep. Nodular spreads deep early, so that's bad. But at the end of the day, Ashley, you know, you said, does it affect your management? It does not. It's all about depth. It's all about depth. So you can predict the depth based on the type, but ultimately, a nodular that's 1 millimeter is the same as a superficial spreading that's 1 millimeter as far as prognosis and management. So these subgroups just kind of help you sort of sort them in your mind and give you some idea of what they're going to look like when they present. But ultimately, it's all about the depth. So superficial spreading, most common, generally spreads superficially, so it's a little better. Nodular goes deep early, so that's bad. Acral lentiginous, like you talked about, is you know, on the fingernails, toenails, things like that. The reason that one's really bad is that it generally presents late. So it's been there for a while because people aren't looking under their fingernails and noting, you know, some discoloration. The other thing is that some melanomas are amelanotic, meaning that they just show up as white nodules or pale nodules or whatever color the skin is, nodules. And so often the acral lentiginous are amelanotic, and so they're hard to recognize. And so a lot of times they present with pain because the ungual bed is sort of being compressed, and so it's basically pain from your fingernail being lifted by the melanoma. But by the time they present, they're often already spreading to the node, so that's bad. And then lentigo maligna, the reason that one's good is because it's usually melanoma in situ. So that's generally not an invasive melanoma, and it's often on the face of older people. So you see these really big, it's also called a Hutchinson's freckle. So you see these really big freckles on an older person, think lentigo maligna. And that, again, is usually melanoma in situ. And we'll talk about how to manage all these things. So like you said, it's depth. That's all that's at the end of the day, that's all that really matters on the current staging. That's almost all that matters. So what else matters for staging, Ashley?
That would be whether or not there's ulceration present.
Yeah, good. So ulceration determines your A and B within the T staging. And then anything else that matters? Let's go Bobius or any other second years on. Bobby, anything else that matters?
I mean, mitotic rate used to be a part of this staging.
Yeah, good. So it's still, mitotic rate kind of can still tip the scales for you, but it, like Bobby said on AJCC 7, it was part of the staging. AJCC 8, it has fallen off. It's no longer part of the T stage. And then what else can tip the scales for you if you're kind of tell you whether or not to be more worried about it?
I'm
Lexi?
LVI.
Yeah, sort of. So that kind of falls into the sort of category. So there's kind of a few things. The next most common thing that people worry about is Clark's level. What's Clark's level in a melanoma? What does that mean, Lexi?
So what level it penetrates below the epidermis.
Yeah, I have a picture somewhere, but I can't remember where now. I'm going way too far. Okay, we'll come back to Clark's level. If you don't know what that is, I'll come back to it. But yeah, so the things that matter, depth by far the most important, ulceration next most important, and then mitotic rate and Clark's level can kind of tip the scales for you if you're thinking, well, maybe this is a higher risk T1. These might clip this or tip the scales. Okay. So why does depth matter? Because it predicts survival. So, this is just one of these kind of seared data graphs where based on the depth of the melanoma, you can kind of give an idea of the survival. Now, this does not take into account nodal staging, right? So nodal staging is also super important for survival. So, but it just drives home the point that the deeper you get, the worse the prognosis. Now, one thing that's a little misleading about this is that it has these arbitrary cutoffs. So I just always put this figure that it's really a continuous relationship. So the deeper you get, the worse your survival, and there are no step offs. It's not like this based off 1, 2, 3 millimeters. It's a continuous curve. So the deeper you get, the worse it is, whether that's 0.9 versus 1.0, it's always worse. Let me see what's going on here with these comments, sorry. All right, Alex, you brought up desmoplastic melanoma. Let's talk about that at the end. It is important, especially for the senior residents, but I want to kind of get through the basics first. All right, I lost my pictures of everybody. Hold on one sec. All right, so can you guys see that there? So 0.9 millimeter, what's her T stage, and what do we need to do? Who's out there? Frank, talk to me, Frank.
So she's 0.9. Do we know if she has ulceration or not?
Just give me the T stage first.
She's a 1B.
Yeah, so does ulceration matter for this patient? It's a little bit of a trick question, but
not for 1B. For her depth, it doesn't matter. It's going to be 1B, period.
Yeah, good. So that's perfect. So it does, ulceration is important, except in this patient. So ulceration doesn't actually matter for this patient. Now, it might tip the scales for you a little bit, but for T staging her, ulceration doesn't actually matter, and we'll talk about why in a second. So her T stage is T1B. So how high does T1 go?
T1, it goes to 1 millimeter.
Yeah, good. So what margin do we need for that, for a T1?
So you need a 1 centimeter margin.
Okay, good. So simple breakdown here. This is what you need to memorize for the test, and then we'll get into the finer details. But in situ melanoma, what margin do you need?
0.5.
Yeah, half a centimeter. T1 is going to be up to 1 millimeter. You need a 1 centimeter margin. T2, what's that?
1 to 2.
Yeah, and what do you need as far as margin? Oops.
1 to 2 centimeters.
Yeah. And then T3 and T4, anything over 2 millimeters, what margin do you need?
Greater than 2, or you need 2 centimeters.
Yeah, 2 centimeters. So when you say you need a 2 centimeter margin, how big of an incision are you going to have to close?
Pretty large. It has to be like an elliptical incision, so that you can get the appropriate margin circumferentially. So you got to have a pretty
Do the
large
math for me.
incision.
So
it's a 3 to 1
melanoma
ratio.
itself is 1 centimeter, and then you're going to have to take a 2 centimeter margin on each side, right? Let's say it's a 2. Sorry, on this one you would just take 1, but just go with me. If it's a 2 centimeter margin, 1 centimeter melanoma, 2 centimeter on each side, that's 5. And then how long does your incision have to be? You said 3 to 1, right?
Yeah, it's 3 to 1.
15 centimeters. So that the point is that, you say like, oh, 2 centimeter margin, no big deal, but it turns out that it's a massive incision. So we try not to make the margins bigger than they need to be. So are you aware of any of the data behind these margins and kind of where we came up with these numbers?
There were several trials done.
And what has actually been shown to ever make a difference? Any idea?
Well, the distance of your margin has been shown to make a difference. Like, you don't have a better prognosis with these massive margins greater than what we've established now.
Yeah, I think the point I'm trying to make, it's probably not very clear, but there's not great data for this. And so, pushing to get a 2 centimeter margin for a 1.5 millimeter melanoma, there's really no data to support that. So, you have to kind of keep that in mind when you're making these huge incisions to get a 2 centimeter margin when the data really isn't very strong. So the big studies that you should be somewhat familiar with, 2 millimeters or less, 1 versus 3 centimeters, no difference. So, up to 2 millimeters, a 3 centimeter margin, at least we know, doesn't matter. Now, 1 versus 2 is being studied now, and some people think it matters. But 2 millimeter or more, so T2 plus, 2 centimeters versus 4 centimeters has been studied, no difference. So why was it 2 centimeters? Because that's what the investigators thought, right? So maybe 1 centimeter versus 4 didn't matter in this. Now, the one that's shown a small difference, T2 or plus, 1 versus 3, and there was a melanoma-specific survival increase with a 3 centimeter margin, but no difference in overall survival. So this is the data we use to say, listen, if you're T2 plus, if you're 2 millimeters or more, that should be T3. Sorry, I screwed that up. So if you're 2 millimeters or more, you need more than a 1 centimeter margin. Now, nobody goes out to 3. People stop at 2, but that's really the only data that we have to support bigger margins. So, the point is just like, when you get in between that 1 and 2 in particular, don't go crazy trying to get a 2 centimeter margin on somebody's face when it probably doesn't matter. So why do you need a margin, Alex? What are you trying to eliminate?
Like local recurrence, and then also just for staging purposes of what I put up there previously.
Yeah, I mean, it's really that the deeper they are, the more you worry about like a microsatellite. Like you said, it's local recurrence, but that's probably from you not getting a wide enough margin around some little microsatellite lesion. But I don't know. I mean, the margins are a little bit silly because it's not really how melanoma spreads. It does spread radially at first, but not dramatically, and then it goes through the lymphatic. So I don't know. I just don't think there's great data to push you to take huge margins of melanoma, and you kind of have to keep that in mind. Because the wider your margin, you end up with these giant incisions. All right, so what else does this patient need, McGovern, besides a wide local excision? A T1B?
So you do a sentinel lymph node biopsy?
Yeah, who do you do a sentinel lymph node biopsy on?
I think you do it all on anyone greater than T1B. or a lesion 1 centimeter or 1 millimeter depth, or evidence of T1B disease, because they have a greater risk, greater than 5% of having travel of melanoma to the lymph nodes.
Okay, good. So who doesn't get, so talk to me about T1A. Who doesn't get a sentinel node?
So anyone with less than 1 millimeter and no evidence of ulceration.
Okay, so that's the old staging. This is what changed in the last couple of years. So there's another criteria. So T1 is up to 1 millimeter. T1A is not ulcerated, and there's another criteria. And again, this just changed. Frank.
The mitotic rate.
No, that's old too. Bobby. What's the new staging say?
Less than 0.8 millimeters.
Yeah. So that's what changed, is that T1B became either an ulcerated T1 or between 0.8 and 1 millimeter. So the other thing that changed is they used to talk about 0.75, or they used to go out to 2 digits after the decimal point. Now you always have to round up. You can only go to 1 digit after the decimal point. So all melanoma is now staged based off of a tenth of a point, or a tenth of a millimeter. No, a hundredth of a, yeah, a tenth of a millimeter, not 100. So, okay, so this is what changed, right? So T1 is still up to 1 millimeter, but T1A is less than 0.8 without ulceration. If you're either less than 0.8 with ulceration, or you're 0.8 to 1 with or without ulceration. So again, ulceration does not matter between 0.8 and 1 millimeter. That's why I made it a 0.9 millimeter melanoma. So ulceration does not matter here. These are all T1Bs, but T1A has to be less than 0.8 and without ulceration. And the reason that, and then, we already talked about this stuff, but the rest of the T stages with ulceration is B, without is A. It doesn't really matter, in all honesty. It matters for staging, but it doesn't matter for your management, because who gets a sentinel lymph node biopsy? No, if you're T1A. If you're T1B, the NCCN recommendations say consider. So this is where things like mitotic rate, Clark's level, all those things might factor into your decision to help you make a decision on whether or not to do a sentinel node. And age, we'll talk about those factors. And then everybody else gets a sentinel node for sure. Okay. Casson?
May I ask a question about sentinel node biopsies in a T1A tumor? I feel like if I showed up with a 0.5 millimeter melanoma, I would want one for kind of peace of mind and my own knowledge. Now, I know it doesn't affect adjuvant treatment, but am I crazy? Am I crazy for thinking that?
Well, it comes down to your risk, right? So it's a lot like if you're doing a prophylactic mastectomy, should you do a sentinel node, right? So in my mind, the risk of having a positive node has to be higher than the risk of lymphedema from a sentinel lymph node biopsy, and that number is somewhere around 2 or 3%. So if your risk of having a sentinel node is less than 3%, then you probably shouldn't have a sentinel node. And so, what are the risk factors for T1 tumors that have a positive sentinel node, since you asked the question?
Well, like we talked about, ulceration, mitotic rate, depth.
So ulceration, any mitoses, so anything over 0. So some people get confused about 1 or 0, but any mitoses is a risk factor. And then Clark's level 4. So let's come back to Ashley. What's Clark's level?
I think you said it was the depth of invasion, like what level it goes to in terms of like.
So be careful about calling it depth, right? Because depth is a measurement. This is about which layer it goes into, right? So just into the epidermis, into the papillary dermis, the reticular dermis, papillary reticular interface is 3, and then reticular is 4, and then if you go all the way to the subcutaneous fat, it's 5. But so Clark's level 4 or greater increases your risk over 3%, and probably even more than that. So if you were a T1A, and why would you have a different Clark's level based on the different depth, or on the same depth? So let's say you have a 1 millimeter melanoma. Where is it going to be a Clark's level 2 versus a Clark's level 4? Why would that be the case?
I'm not really sure.
Yeah, so that's why this is sort of confusing and why it matters, right? Is that the different layers of the skin are different based on how thick the skin is, right? So the skin of the back of your hand is very, very different than the skin of your back, right? So the skin on people's back is very thick. The skin on the back of somebody's hand is very thin. So a melanoma in those two places are a little bit different. And it's kind of like, T staging on the esophagus or the stomach, right? It's where are the lymphatics. So once you start getting into this papillary reticular interface, you're starting to run into lymphatics. And so once you're into Clark's level 4, you're definitely in where the lymphatics run. And so that's why it increases the risk of sentinel nodes. So if you had a 0.5 millimeter melanoma, David, that was a Clark's level 4, then I would say, yeah, get a sentinel node, because your risk of positive sentinel node goes up. So this is kind of the down and dirty summary of the numbers, is that if you're less than 0.75, your risk is less than 3%. If you're between 0.75 and 1, it's up to 7%. And that's like a conglomerate of a bunch of different studies. But then there are other studies that identify these risk factors. The other one is nodular growth, right? So we talked about at the beginning, nodular subtypes grow deeper, quicker. They're a little more aggressive. So that might tip the scales for you. And then tumor regression. So under the microscope, the pathologist may talk about tumor regression. That's kind of like central necrosis of a tumor. And that generally means that it's growing fast. That's different than a immune infiltrate causing death. So that's a subtlety that the pathologists have to look at. And then young age. So again, David, you're right. I mean, you're young. So some people would say anybody your age, just get the sentinel node so you know for sure. But the bottom line, we'll talk about MSLT1, but the reason that we don't do it for most T1s is that it didn't really show to make a big difference in melanoma specific survival. And so, for the really thin, actually, no, I'm sorry, I'm misspeaking. There weren't really many less than 0.75 in MSLT1. So that data doesn't apply. But the bottom line is we just know that the rate is really low. So it's a balance between your risk of developing some complication and your risk of having a positive sentinel node. So, but I think if you're 0.5, but you have a bunch of these risk factors, then yeah, do the sentinel node. It's not, that's why it says consider, because it's not kind of hard and fast. All right, so let's go, Patrick. Where are you going to do your sentinel node biopsy on this lady?
Pretty tough to say. I mean, I would think either like the supraclavicular or posterior cervical chain, maybe the axillary. But if I had a real concern, I could do lymphoscintigraphy to find the draining nodal basin.
Okay, yeah. So the point is to do lymphoscintigraphy. So what nodal basin? Who knows? I mean, literally, nobody has any idea. So don't guess. There's this old thing called Sappy's lines. Anybody ever heard of that, Pat? What does that mean?
I recall Sappy's lines are like the cutaneous lines of the skin where you try and make your incisions along.
No, that's Langerhans lines.
Yeah.
Alex?
No.
Nobody has any idea. All right, I love it. So this is how they used to decide, basically, before lymphoscintigraphy. You just divide the torso into 4 quadrants based on this line down the middle and the line at the umbilicus, and you go 5 centimeters out. If you're in that 5 centimeter margin around these lines, you have no idea. Otherwise, they would say, well, this is probably in the axilla. And what do you think the accuracy rate of that was?
Quite poor.
It was about 50%. So it was like flipping a coin. So maybe sometimes you were right. But the bottom line is don't do that. Don't guess. So you do lymphoscintigraphy. So lymphoscintigraphy, you inject that nuclear medicine dye into the tumor, and then you kind of see where it goes. Now this is a bad example, right? Because this is pretty obvious where it's going to go. But I do lymphoscintigraphy for all melanomas just because why not? It's available, and this could go to the a superclav or something. And melanoma is notorious for doing weird things, so I just always do lymphoscintigraphy. So we used to get the old school images like this, where it's like it's like the sestamibes, and you're like, maybe it's there, I'm not sure, it's hard to tell. But now we get spec CTs on everybody, so it's great. You can tell exactly where the node is. It just makes your life a lot easier. So always do lymphoscintigraphy for melanoma. It just makes your life a lot easier. If you're at a place that doesn't have lymphoscintigraphy, you probably shouldn't be doing this, is the reality, is because you just don't want to screw it up. It's not a high risk procedure, but if you mess it up, it makes everybody's life a lot harder. All right, and then we're gonna do a sentinel lymph node. You guys know how sentinel lymph node works, right? This is more for med students, I guess, but same thing. You inject the dye and then you use a little probe in the OR to find the node. I always do nuclear medicine and blue dye, so technetium and blue dye, 2 dyes, has been shown to improve the accuracy of the sentinel node, and more important, the identification rate. So the worst thing is if you go to the OR and you can't find the sentinel node, then you're like, what do I do? It's horrible. Okay, MSLT1. So the question in this trial, among patients who had a wide local excision for melanoma, does sentinel lymph node biopsy with reflex completion lymphadenectomy, so that means anybody who was positive on their sentinel node got a lymphadenectomy in this trial, improve melanoma-specific survival compared with just watching the nodal basin. Kat, what's the answer? Franklin says no.
The answer is no. Sorry.
So it's complicated is the answer. It kind of does. It kind of does. So we'll get into it. So 2,000 patients. The thing to keep in mind here is that they called thin melanomas between 1 and 1.2, which is super annoying, right? Like, why would they, you know, it's like they use this arbitrary number of 1.2 as their cutoff for intermediate thickness. Most people think of intermediate thickness over 1 millimeter. So that's kind of where we apply this data, despite the weird cutoffs they used. So randomized to either sentinel lymph node biopsy or observation. If you had a positive sentinel lymph node, you got a lymphadenectomy. We're going to talk about MSLT2 on Wednesday, but just keep that in mind for this trial. And then if you were in the observation group, if you ended up with a clinically positive node, then you got a lymphadenectomy. What was the rate, Franklin, you probably know this because you've been studying for MSLT2. What was the rate of positive sentinel lymph node?
I don't know the rate.
Okay, it's not super important. The reason it's important, it was around 17.4%. It was exactly 17.4%. But the reason that's important is, what do you think the final rate at the end of the trial in the observation arm of nodal positivity was?
It wasn't very high. I don't know what that number is either, but
yeah, it ended up coming pretty close. So that's the bottom line, is that eventually these nodes, most of them became clinically evident. Now, there's some with MSLT2, it's kind of like, does that matter? It's not clear, but it's a little bit different than breast cancer, where we think that there are probably patients with positive nodes who will never become clinically evident, and MSLT2 would argue that a little bit. But in this trial, roughly the same amount of patients ended up with positive nodes. Now, they had long follow-up for that to happen, so it took a long time. But primary outcome, melanoma-specific survival. Intermediate thickness, no difference. Intermediate thickness with positive nodes. This is where people argue for sentinel node. So if you had an intermediate thickness melanoma and you had a positive node, your melanoma-specific survival was better if you had a sentinel node. So in other words, if you have a positive node, you're much better finding that out right away than later. Now, why is that the case? Probably because you're watched closer, you're more worried, and these patients did get dissection. So this would argue that if you have a positive node, maybe dissection matters. The really difficult thing about interpreting this data in 2020 is that now we have actual good medical therapy. Back then, they had no good medical therapy. So I would argue that sentinel node is even more important now, because it's going to decide whether or not you get adjuvant therapy, and adjuvant therapy actually works. So the bottom line is that sentinel node is not therapeutic, but it's prognostically very important, because it leads to follow-on therapies that probably make a difference. So Kat, you're right, it didn't matter. But if you had a positive node, it did matter. So that's why sentinel node is important. It's important for prognostic information, not for therapeutic. So disease-free survival was improved in intermediate thickness and thick melanomas. So why was disease-free survival improved? Because you took out the node, and so you took out some of the disease. So you had less chance of recurring in the axilla if you had a dissection. So these patients with a positive node got dissection. So yeah, their disease-free survival is going to improve, but their melanoma specific, did they die of melanoma? That survival did not really change, except in the patients who were node positive. So this just tells you that what's important about axillary, about sentinel node, is you're trying to figure out who has axillary disease, who has nodal, not axillary, who has nodal disease. And that actually is important. But is there a therapeutic benefit to a sentinel node? No, not at all. All right, so prognostic value, again, super important, prognostic value. Everybody good on MSLT1? Do a sentinel node because of prognostic value. That'll be on the ab site, not therapeutic, prognostic. All right, so these are the take homes. I think we kind of beat this to death. Here's the recommendation though. Recommended for T2 or greater, and then consider for high risk T1, which is currently defined as greater than 0.8 or ulcerated. And then we talked about those other kind of questionable risk factors. But this is at the end of the day, what you take home is that you always do sentinel node for T2 or greater, or high risk T1 defined as greater than 0.8, ulcerated, or maybe the other things. Everybody good on that?
T1B.
Yeah, exactly. T1B, you do it. Well, although the actual recommendation says, it says some vague wording like consider and T1B. So you don't have to do it for T1B. That's the reality. If you have an 80-year-old who has a T1B, don't do a sentinel node, right? All right. I can't advance. What's happening? Oh, I have too many animations. Sorry. All right. Axillary dissection. We're going to talk about this on Wednesday, so I'm going to go very briefly over this. No change in melanoma-specific survival with an axillary dissection in the patients with a positive node. We rarely do exceptions anymore, or do dissections anymore, except in certain scenarios. So, Tassin, when would you do a nodal basin dissection for a positive sentinel node in melanoma in 2020? Again, we're going to talk more about this on Wednesday, but.
I guess so. If you're doing a sentinel node, by definition, they were clinically node negative, because I think of it mostly as a clinically node positive patient. So,
yeah, so that's a different question, right? MSLT2 did not look at clinically node positive. If you're clinically node positive, you need a dissection. That's at least currently. You might do neoadjuvant therapy and stuff like that, but the current board answer is do a dissection for clinically node positive. All this discussion is around clinically node negative. So instead of doing dissection, what are you going to do? What's the standard right now?
You're going to do ultrasound surveillance.
Yeah, so if you can't do ultrasound surveillance, you got to do a dissection. So basically, if they're clinically node positive, we talked about that. If they can't be followed, so that would be somebody who is just unreliable and they're going to disappear, you might do it. Or if they already have lymphadenopathy for some other reason, but they're biopsy negative, like they have lymphoma or something crazy, right? They have a concomitant lymphoma and all their nodes in that basin are big, then you can't follow them. So you just got to do it. And then some people argue for patients who are at very high risk for additional positive nodes. So that would be multiple positive sentinel nodes, big deposits, parenchymal versus subcapsular mets in the lymph node, ulcerated primary, maybe like a T4 ulcerated, maybe, your risk is really high, maybe you would do it. And then a young patient who's at high risk. Those are all very, very questionable. Board answer in 2020, I would say, is Q4 month ultrasound. Okay, well, we'll talk about more of that on Wednesday. Okay, what's this? Cat.
In-transit lesions.
Okay, good. What does that mean? What's the difference between satellitosis and in-transit? This is like a stupid board question, but they like to ask it.
So in-transit lesions are lesions in the dermis or the sub-Q that are greater than 2 centimeters away from the primary lesion, between to the nodal basin, local regional nodal basin.
Can't tell if you're just pulling things, you're looking up while you pull things from your memory, or if you're looking at some screen that has all the answers.
There's nothing up.
I'm just kidding. All right, yeah, good. So 2 centimeters is a cutoff. So to be a satellite lesion, by definition, it has to be more than 0.3 millimeters, and then up to 2 makes it a satellite, and then more than 2, it's an in-transit met. So these are probably melanoma cells traveling through the lymphatics that get clogged up and then form a little tumor right there. Is that a good thing or a bad thing, Kat?
Is having in-transit lesions does
that sound good or bad?
It sounds bad.
Yeah, that's bad. That's bad. So yeah, we'll talk about it a little bit, but how do you treat in transit? If you have, Alex, let's say you have this, this lady with this whatever melanoma and she has a bunch of in transit mets, but no other disease, what would you do?
You could give her radiation therapy or TVEC.
Yeah, so TVAC is a great answer. That's kind of the newer answer. What are the older answers that people don't do very often, but is kind of out there, and it may be on your test? So it's isolated to the limb. That's sort of
You
a
could do
clue.
imiquimod, or however you say that word, or some other like ablative, like localized ablative therapy. I wouldn't recommend amputation. I think that's probably an old answer.
Anybody else know what I'm talking about? Disease that
Can't
is
you put
isolated to the limb.
It's an isolated limb
perfusion.
chemotherapy
Yeah,
infusion.
good. Isolated limb perfusion or isolated limb infusion. So these are the kind of simple pictures. I've never done this. You know, people still do it though. So it does have some efficacy. So isolated limb infusion is where you have an arterial and a venous catheter. And basically this is like HIPEC for the leg is kind of one way to think of it. And so it's regional therapy to the affected limb. And then there's isolated limb infusion, where all you're doing is infusing, and then you put a tourniquet up and let the body kind of deal with it. So just kind of be aware of those. Those are regional therapies for the limbs, not done often, but they are still kind of out there. Like Alex said, now there's TVAC. What's TVAC, Alex?
It's like telemagene something or another, which
Yeah, what is it,
basically
though?
is localized immunotherapy.
Yeah.
I can't say the other word.
Okay, so it's basically a herpes virus combined with GM-CSF, which is like an immunoadjuvant. You inject it right into the tumor, and it lyses some tumor cells, and then the GM-CSF turns on the dendritic cells to spark an immune response. So the idea is you break up some tumor cells in the presence of an immune response. Now you get CD4 and CD8, so mainly CD8 T cells that are activated against the tumor. So it's like a cancer vaccine, but you're doing it through the patient's own tumor by breaking up the cancer cells in the midst of this kind of immune response. And then you should get a systemic effect, meaning the immune system will be primed against the tumor and go kill tumor cells elsewhere. So what you see when you do it is that if you have all these in-transit Mets, you'll inject a few of them, and they'll come back a few weeks later, and those will be going away. And then after a few rounds of therapy, the people who respond well, all their other in-transit Mets will start disappearing too, even though you haven't injected those. So that's the idea, is you end up with a systemic immune response to the tumor based off that local initial response. And then you can combine that with a checkpoint inhibitor. That's kind of where the trials are going now, and spark that immune response even more. Okay, so what's the other thing we need to do in these patients? And then this patient has clinically node positive. What else do we need to do before we treat them? We're running out of time. 10 minutes. Bobby, what are we doing?
Figure out the metastatic disease.
Yeah, you got to stage them. Okay, so don't forget that on your oral boards for the chiefs. Always remember when you have a cancer patient to stage them, because that's how they'll trip you up, is you'll get into the treatment and you'll never have looked for a MET. And then they say, oh, what about, they got a chest x-ray. What about this big Goomba in their chest? So always stage them, right? So who needs systemic staging? Basically anybody with node positive disease. So this is the breakdown of nodal stages. I would not worry too much about this. If you really want to crush your oral boards, these people need a brain MRI. So if you get into N2 plus disease, so this is just to show you where the in-transit Mets are, and then N2 is more than one node basically. So anybody N2 or below needs a brain MRI to look for brain Mets specifically, but otherwise just say you're going to get a PET scan. And then on your oral boards, I would just say get a brain MRI on everybody. It'll be a waste on the N1 people, but who cares? So everybody gets a PET scan, everybody gets a brain MRI for advanced melanoma, and that means node positive or above. So in transit definitely counts as node positive. So that's N2C or N3 disease if you have in transit Mets, depending on whether or not you have other Mets. Okay. All right, so who needs imaging for metastatic? Anybody node positive, and then basically 2B or C needs a brain MRI. All right. Okay, so now we have metastatic disease. What do we do now, Alex? Or Lydia, I haven't picked on Lydia yet, sorry. I see Lydia, I saw Lydia. How do we treat melanoma medically? So now this patient is no longer a surgical candidate.
So you would want to biopsy the lesion just to ensure that
they got
it's
metastatic
not
melanoma.
something.
What's the medical therapy? It's metastatic melanoma.
So you can do PD-1 inhibitors, and if it's a BRAF positive, you can use a BRAF inhibitor.
Okay, that's pretty good. So yeah, so BRAF positive. So this is the big thing you got to take home is when somebody has metastatic melanoma, the first question you should ask is what's their BRAF status, because that determines how they're treated in a lot of ways. So if they have the most common mutation BRAF V600, if they have a V600 mutation, then they can get BRAF inhibitors. What else do they get, Lydia, besides a BRAF inhibitor?
Is the PD-1 inhibitors?
So it's really, so the point is that you have to give something, another inhibitor with the BRAF inhibitor, or else the tumor mutates around it. So BRAF MEK. So anytime you say BRAF, say BRAF MEK, BRAF MEK. Just keep in mind that the MEK inhibitor always goes with the BRAF inhibitor now. So this is like another hour-long talk. I'm going to try to combine it into 4 minutes. So medical therapy, there's two options. Basically, you have immunotherapy. So you said PD-1 inhibitors. Think of the broader class of immunotherapy, and then you have BRAF MEK. So if you don't have a BRAF mutation, your only option is basically immunotherapy. If you do, then you can get BRAF MEK. How does immunotherapy work? So when the T cell is activated and it binds to a tumor cell, it needs these kind of helper things. So that's the way to think of it, is CTLA4 is a helper of the T cell binding to the antigen presenting cell, and then PD-1 is a helper of the T cell when it's binding to the tumor cell. So the tumor makes PD-L1, the T cell makes PD-1. So essentially, I'm sorry, I'm saying this completely wrong. These are not helpers, sorry, these are checkpoints. So I just totally screwed that up. So checkpoint, checkpoint, checkpoint. That's kind of the whole point. I lost my pictures again, sorry. So these things turn down the T cell. The CTLA4 and the PD-1 turn down the T cell. So the tumor, this is a tumor escape mechanism, basically. So when the tumor wants to escape the immune response, it overproduces this PD-L1 antibody, or I mean this PD-L1 receptor, and then the T cell goes to apoptosis. So what we need to do to prevent that escape is we need to bind up the CTLA4 and we need to bind up the PD-1 and PD-L1. Does that make sense? So these are checkpoints that make sure that the immune system doesn't go crazy, and we want to basically turn off the checkpoint. So the best analogy is this is taking the foot off of the brake of the immune system. So the immune system has to have brakes or else it'll just go crazy. This is taking your foot off of the brake. So you're asking the immune system to go crazy, basically. So you need some response, you need some immune response for this to work. So melanoma is a very immunogenic tumor. So a lot of people already have an immune response in place. And so now you're just turning that up. Same thing like the concept of adding TVAC to a checkpoint inhibitor is you're trying to turn on the immune system with the TVAC, and then you turn up the immune system with the checkpoint inhibitor. So there are two types of checkpoint inhibitors, basically CTLA4, which is ipilimumab or Yervoy, you need to know that name. And then the PD-1s are Pembro and Nivo, pembrolizumab, nivolumab. I'm sure you've seen commercials for Opdivo and Keytruda. So they're effective in melanoma. They're somewhat effective in other things. Particularly now, any tumor that has PD-L1 staining on it can now get these drugs. So that's kind of an interesting, unique thing. Doesn't matter what class or what organ it comes from. If it has PD-L1, it can get those drugs. And then this is kind of the newest player is atezolizumab. That's a PD-L1 antibody. So there's a ton of these. There's like 40, but these are the ones you should probably be aware of. So checkpoint inhibitors. So 2010, the first trial was published, IPI plus a vaccine versus the vaccine, basically, and the IPI arm did a lot better. So that was kind of like IPI plus placebo or versus placebo a little bit, but overall survival is still just 10 versus 6 months. Not great. This is for metastatic melanoma. And then IPI plus dacarbazine versus dacarbazine did a little bit better. So now IPI is kind of becoming the new drug. The problem with these early trials is that we didn't really know how to handle the complications. So what's the big toxicity of a checkpoint inhibitor, Franklin?
Autoimmune colitis.
Yeah, so that's the one that killed people, was colitis early on, but basically autoimmune disease, right? You turn the immune system up. The bad problem with that is that you get autoimmune disease. So in these early trials, 2 or 3% of patients were dying from colitis. And so that was a little scary, but we're getting better at managing it. You watch patients closely, you give them steroids if they have these problems. All right, so now Pembro comes on. So Ipi versus Pembro. And basically what you found is that the adverse events were about half as much with Pembro versus Ipi, and the progression-free survival was almost double. So you're getting twice the oncologic benefit with half the toxicity with these PD-1 inhibitors. So now those kind of overtook the ipilimumab. But then we combined the two. We said, well, if one is good, two is better. So basically the blue line's Nivo, the orange line is Nivo plus Ipi. So it does do a little bit better, but the adverse events, grade 3 or 4 adverse events, was over 50%. So you get some bang for your buck by combining these drugs, but you get a lot of toxicity. So this is for patients generally who fail Ipi, then they add Nivo, or if they fail Nivo, then they add Ipi. So combination therapy is out there for metastatic disease for sure, but it's generally in patients who fail the first line. So then these drugs moved into adjuvant. So this is an adjuvant stage 3 trial, EORTC trial. Grade 3, 4 adverse events. This is versus placebo. You can see they're pretty high. 5 patients in the Ipi arm died from immune-related toxicity, but it did work. So, you do get some improvement. Blah, blah, blah. And now Nivo versus Ipi. Nivo is better than Ipi. Okay. And less patients had immune reaction. So same thing as a metastatic. And then the last thing, oh, I didn't show it. Anyway, so in the adjuvant setting, your tolerance for toxicity is a little bit lower. So people are starting to combine Nivo and Ipi in the adjuvant setting, but it's not very common because the toxicity is too high. So generally in the adjuvant arm, meaning node-positive disease that has been resected, you're going to just go to Nivo or Pembro. So you're going to go to one of these PD-1 inhibitors. But anyway, checkpoint inhibitors are the way to go for melanoma unless you have a BRAF mutation. So this is kind of just a simple down and dirty. This picture is probably the best. It's simpler. So you'll hear all these mutations when we talk about cancer, right? RAS, RAF, MEK, and then ERK is kind of the newest one. But the bottom line is you get a growth factor, it turns all these things on, and then the cell grows. If any of these becomes mutated, it just gets turned on constitutively, and you can't turn it off. And so that makes the tumor grow. So we're trying to block these things with drugs. Essentially what they found is they gave people BRAF inhibitors and they responded. There was like a 50% response rate. And these are in metastatic patients who had basically no treatment arms before checkpoint inhibitors. But what happened was 6 to 8 months later, their tumor started growing again. And that's because the tumor just mutated around the BRAF. So it put a bunch of selection force onto the MEK, and now you started getting MEK mutations. So if you just give one drug, the tumor just kind of finds its way around that and goes to the next step in the progression. So what we do instead is we give a BRAF inhibitor and a MEK inhibitor, and now you block both drugs. And then now there are these new drugs that are ERK inhibitors. So that's probably gonna be the next thing, is that you're gonna get a BRAF, MEK, and an ERK inhibitor, all three combined. And then, some people are combining that with checkpoint inhibitors too. So there's crazy stuff going on. But the bottom line is that you need to block both to have any sort of meaningful effect. So this is basically a BRAF inhibitor versus a BRAF MEK inhibitor. And you can see that both curves continue to go down. So eventually the tumor does mutate around both, but the time is much longer with the combination. So you always give a BRAF with a MEK inhibitor. What's the big side effect with BRAF inhibitors? Anybody know? Alex, you look like you said something, but you're muted.
I thought it was diarrhea, but I don't remember.
Yeah, you can get some diarrhea, but that's not the big thing. The big thing is skin cancer. So that's the irony of these drugs, is that they cure melanoma but cause squamous cell cancer. So you can get these skin cancers from it. So you have to watch these patients very closely. They're generally not very aggressive, and you just excise them. But you do have to watch these patients. It's mainly skin toxicity. So a lot of rash and then skin cancer. So that's the one thing you have to watch for these drugs. But anyway, this is just another trial. Same thing. BRAF MEK works better. This is a versus placebo, but BRAF MEK is really the standard now. All right, so two main options: immunotherapy versus BRAF MEK. You have to have a BRAF mutation, V600E, to get these drugs. There are a couple breakdowns of those mutations. You can get really into it, but bottom line is if you have a BRAF mutation, you can get BRAF MEK or checkpoint inhibitors. There's a lot of debate on which one you should give first, and that's totally unanswered, not something you need to worry about. But you can still get a checkpoint inhibitor if you have a BRAF mutation. That is something you need to understand. So BRAF mutation, you have two options. BRAF wild type, your only option is immunotherapy. And I'm out of time. So these are just take homes, right? So know these for the test and for real life. Understand when to do a Sentinel node, right? And that's it. Finished exactly on time. Questions about anything?
Can you explain exactly who gets TVEC then?
Yeah, so TVEC is purely for local disease. So that's really just for in-transit Mets. So there's no hard indication for TVEC. Like the NCCN guidelines say it's an option when you have basically unresectable local disease. So that mainly means in-transit Mets. So if you have, one of the options for in-transit Mets is to do a huge wide local excision. So if you just have, if it's a small enough area on the thigh or something and you could excise it and then skin graft it, that is an option. But when it becomes to the point where it's unresectable, that's where TVEC is an option. But it's really just for that local disease in the skin. It's not for like lung Mets or nodal Mets. Now, some people are talking about giving it for nodal Mets, but that's not the right answer right now.
Okay,
I think we should get moving on to M&M, guys.